I think you're all joining because you're interested in us talking about a multidisciplinary approach to supporting kids with Tourette syndrome. That's what we're going to do today. We're going to be introducing to you, and I love this quotation, Woods and Piacentini are two of the leaders in developing what you're going to be, if you don't know about it now. It's called CBIT, Comprehensive Behavioral Intervention for Tics. And you can see as they started to promote this around within the TA community around the country, they said, now that our collaborative research project has shown that CBIT can reduce severity. Now, this is a methodology that's non-pharmacological, which is why, hence the reference to multidisciplinary, that we can work closely with the Tourette Association. Interesting, I work with the Tourette Association, and the presenters you're going to see today are all employees of Children's Hospital Colorado, which is now embracing this methodology robustly. And it says, and we can establish training programs across the country. That's part of what we're doing today too. People will be able to use this who aren't with us today because it's going to be available online on our websites, and it's going to be available around the country for TAA to use to promote the concept of CBIT. We're very excited about what Children's Hospital has committed to doing. You're going to learn about that today. This presentation, I should acknowledge, is a grant from the National Tourette Association of America and CDC. CDC and TAA combine with CDC's monies to produce a lot of wonderful, wonderful presentations and materials. If you've been on the TAA website, TAA.org, you've seen their work. If you've gone on our website, ColoradoTAA.com, everything we use there, we steal from the TAA because their materials are so good, and we want to share them with our TA families in Colorado. This is also, we have this grant, and we said this is the first thing we're going to do as a collaborative annual event with the hospital and the Colorado TA organization. And you should know, because we're going to be talking about this collaboration has resulted in the establishment of a multidisciplinary Tic Clinic that Children's Hospital is endorsing. In fact, we had our 7th session with families yesterday. These are for patients within the Children's Hospital system who have seen a neurologist that get referred to the Tic Clinic, and they get assessed to see if perhaps a non-pharmacological approach to helping them manage their tics will work. And so the people that do that assessment are hospital employees, as well as have been trained and certified by the TAA to use this methodology. The presenters you're going to see today are the founding members of the Tic Clinic. And but it's important to note, and I represent TAA in Colorado, that there are a lot of families have already been supported and helped by the Tic Clinic, but I also work with other neurologists and other occupational therapists certified to deliver CBIT support. So that's an important message. We're here to support Colorado TS patients wherever they are, and if you're part of the hospital, you connect them, and if you need help in other ways, you contact me, and it comes up later at Denver TAA.org. And but if you've been on our website, you see that we both publicize this. We publicize a lot of other activities that the hospital and non-hospital are sponsoring. So we're here to do what that quote from those two leading practitioners said to do. Educate the world about CBIT. You're going to get a wonderful overview. Chelsey's going to talk about fundamental tics to put us on the same page, understanding different type of tics when tics evolve into full Tourette's, and going to talk about an interesting phenomenon that you've probably heard about, functional tic-like movements. that have confused the entire community of patients, of doctors, of therapists. So that's going to be a wonderful foundation. Kate's going to talk about CBIT. Kristen's going to talk about other things that the occupational therapist can do. And then any questions that we haven't had the time to answer, because there'll be a little bit of time after each presenter. We're going to save them all. You enter any questions you have into the chat box there. And at the end, we're going to stay. And any questions that we haven't answered, we're going to answer. So I hope you'll stay active. Enter your questions and we'll get to them. Chelsey is going to come next. She's going to talk about the tics, Tourette's, and functional tic-like movements. And I think you're good to go. Yeah. It's Chelsey Stillman, who I mentioned is the director of the clinic.
I'm Chelsey. I am a PA. I've worked at Children's Hospital for 12 years. I've been seeing tic patients for the duration of that time, but I've subspecialized in it slightly for about 1.5 years. And without further ado, we will go forward and do the thing. I have no disclosures. Kind of wish I did, but I don't. No disclosures. So what are tics? So tics are movements. They're sudden, stereotyped, rapid, recurrent, non-rhythmic motor movements or vocalizations. There are kind of two big divisions between types of tics. You have motor tics and phonic tics. Now, motor tics come in two types. Simple motor tics are eye blinking, facial grimacing, shoulder shrugging, and head jerking. Now, complex motor tics usually are not what you start with, but you can develop these later in the course. They involve coordinated movements like bizarre gaits, kicking, jumping, scratching, seductive gestures, copropraxia, which is obscene gestures, and echopraxia, which is some people can actually mimic other people's tics. And then in terms of phonic tics, now there was for a while, there was a debate about whether some of the things we do with our throat and our noses are phonic vocal tics. So everyone just said anything where you can hear it is just a phonic tic, and we threw vocal tics out the window. So we don't really refer to them as vocal tics anymore. They're phonic tics. So simple phonic tics include grunting. Both of my daughters have that one. Barking, moaning, throat clearing, sniffing, hollering, and other noises. Complex phonic tics include coprolalia, which is the obscene words, which is very infrequently actually found in a typical tic patient. Echolalia, repetition of words. Palalia, which is a repetition of your own phrase. So echolalia is actually when you repeat someone else. So if someone will say I want to go to the park, you might say park, 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 park. And palalia is when you say I really want to eat pizza, 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 pizza. So you echo yourself, or echolalia is when you echo other people. Coprolalia occurs in less than 10%. I actually think it's closer to about 5%, which is usually in the form of uttering obscenities. So tics. So this is how we kind of take a history on what is a tic, what is not a tic. In tics, most kids have a premonitory urge or feeling and sensation that is relieved when you execute the tic. So I'll ask the kid, when you do this, is there something that if you hold it in that's bothering you, a pressure, a push, a pull, a something, an itch? Is doing the tic, does that feeling get better? So that would be the premonitory urge of it's kind of a lot of people, someone told me yesterday, it's when you hold in a cough, that feeling gets worse and worse until you cough. So it's a similar urge to that, but kids might feel it in their eye or in their nose or in their shoulder. And that urge or that feeling or that tightness has to get relieved by doing the tic. And then it becomes kind of habituated, and then it starts to kind of be executed without using the frontal cortex to think about it. So you can temporarily suppress them, so either stop them entirely or turn the volume down, but lots of kids will tell me that they then have to get those tics out even more later. So which is why there's a study that looked at what time of day is the most frequent time of day in which kids will tic, and it's actually after school on the way home. 98% of people said that is one of their biggest tic moments is after school in the car on the way home. They have variable severity throughout the day and through the course of the year. They'll wax and wane in nature through the course of the year. Their tics, so lots of parents will kind of say they'll get a tic and then it'll go away and then they replace it with another tic. So there's weird evolving door of first they had an eye thing, then they had a nose thing, then they had a lip scrunching, now they have the lip scrunching and the eye thing. So there's this weird, it should evolve over time. Some tics will stop, again, also to be replaced by other ones. You can also then reincorporate old ones back into your like current repertoire. Motor tics almost always precede vocal tics or phonic tics. Sorry, I broke my own rule. I said vocal tics and I should have put phonic tics. Onset is usually kindergarten through 2nd grade. Now, I will say my 3-year-old has a tic. I think that my opinion is I think that it can typically present before that, but I think it's actually recognized because it starts to worsen in severity around kindergarten. Maximum severity is typically between 10 to 12 years of age. And then you get about 2/3 of kids will have substantial improvement by late adolescence. So what's tics versus Tourette's? So in general, it's all on a scale. I mean, we kind of, to separate them is a little bit silly. I think in some ways you can kind of get more supportive services at school if you have Tourette syndrome versus a tic disorder. So there's kind of 3 big classifications of tics. So you have a transient tic disorder, which is a provisional tic disorder. Those can usually start and usually last for a few weeks. This occurs in about 10% of the average population. So I've actually seen, so they'll have a tic, it'll go away for a few months, and then they might have it again for like a year later. I've seen that this, the data I got this from in UpToDate says 10%. I've also seen data up to saying 30%. I think personally that it's probably 30% because there's probably a lot more kids kind of doing funny things that parents kind of write off. They're probably actually a tic. So most kids with simple motor tics do not require treatment, and their tics have to have started before the age of 18 years to meet criteria. Chronic tic disorder or persistent tic disorder, you can have either vocal, phonic, or motor tics, but not both, for over 1 year. And in that year's time frame, you cannot have gone more than 3 months without a tic. So, or else if you go more than the 3 months, then you probably have like an episodic or transient tic disorder. Again, tics have had to have started before age 18. So Tourette syndrome is really just a phonic tic, a tic you can hear, and a tic you can see, lasting more than a year. And no more than 3 months in between. So really, Tourette syndrome is just chronic tic disorder with a tic you can hear. What causes tics? Short answer, somewhat unclear and probably multifactorial. Long answer, it's been described in a lot of different ways. I'll go into it very briefly here. A disturbance in the mesolimbic system, which is the part of the brain that puts the brakes on movement, leads to disinhibition of the motor system. We do know that imaging studies have found that there's a decrease in the caudate volume, a part of the brain that's involved in motor control. That is smaller in kids with Tourette syndrome. Tic severity in children with Tourette syndrome correlate with reduction in sensory-motor cortex volume. Again, these are things that have been found, but do I use imaging to diagnose kids with tics and Tourette's? No, and that is because kids without that change in caudate volume or without that change in sensory motor cortex volume also have Tourette syndrome. So it's not used diagnostically, but it's felt to be that maybe that's related to the etiology of it. There's another study using PET scanning, which found decreased use of glucose or energy in the basal ganglia. There have been a few genetic studies. There's not really been a great gene cause for kids with tics and Tourette's. We do know that it's genetic in that people who have tics often have kids who have tics, but do we have a lot of really robust gene data with Tourette syndrome? No. So this is the only time I'm going to talk about this because this is like a debatable entity, but although it's been proposed that antibodies to the basal ganglia neurons from group A strep may be involved in the pathogenesis of Tourette syndrome in some patients, there's no evidence that pediatric autoimmune neuropsychiatric disorder associated with strep plays any role in the development of Tourette syndrome. So this is not the purpose of today. This could be a whole other topic, but it is not the cause of Tourette syndrome. Again, we think Tourette syndrome is caused by a lot of different things. So who has it? Tourette syndrome is actually relatively rare. So though transient tic disorders can be 10 to 30% of the population, Tourette syndrome is actually around 0.5%. And again, that probably depends on who you read and what study you're quoting. Males are affected more than females in a ratio of 4 to 1. It's pretty similar across different ethnic groups, though there are a couple studies to say that it's rare in African Americans and sub-Saharan Black Africans. Prenatal smoking may be associated with an increase of TS. The natural history. So how does a typical kid with tics or Tourette's present? So the average age of onset is 6. Disorder is manifested or peaked by around age 11. Again, that's that 10 to 12 age where they really peaks. In 96% of people, they peak at that time. severity of tics, again, usually peaks at 10 to 12. In a study out of Denmark, in terms of like, what does it look like years later? They looked at kids who were a little bit older, around the age of 19. Over kids at age 16, 18% of them have had complete remission, and tics were minimal in 60%, and moderate or severe in 23%. So about 75% of kids will have a significant improvement around age 16. And this is an important number to think about later when I talk about the functional neurologic disorder and the tic-like movements. So for patients with persistent tics, comorbidities are present in many. And whereas people with only Tourette syndrome and no comorbidities, like what we're going to talk about later, is actually only exists in about 37% of the population of kids with Tourette syndrome. And then again, that last statement is there just saying that it gets quite a bit better with time. Comorbidities. So I'm going to talk about the most common. So ADHD is interesting. It often emerges before the onset of tics by about 2 to 3 years. OCD, which is the second most common comorbidity, actually emerges after the onset of tics. So that's an interesting finding. I think compulsions include counting, arranging, hoarding, touching, tapping, rubbing, or error checking. I talked to a kid yesterday who said that every night when he goes, or I don't think currently, but previously when he would go to bed, he'd have to tap the wall in a certain order every night before he went to bed. And he was not sure if he had OCD. And I said, well, I think you answered your own question. Anxiety is very, very common as well, occurring in about 30% of kids. Disruptive behaviors like ODD is also very common, as well as sleep disorders. And the reason I bring this up is clinically, when I talk to patients, I'll say, okay, what bothers you? So you have a couple things. You have ADHD, and let's say you have anxiety. What bothers you the most? And the kid might say, well, my tics actually aren't that bad, but like my anxiety is crippling. And so if you can actually like damper or control some of the anxiety sometimes the tics get better. So we actually kind of think about it as like a whole patient and not individual diagnoses. So it's very helpful for kids with Tourette syndrome to have some of those comorbidities managed. This is an interesting graph that shows these on the left are just disorders, common diagnoses, and the red bar is the incidence of which that diagnosis is found in kids with Tourette's. So for ADHD, you can see it exists in 50% of the population of kids with Tourette's. If you do not have Tourette's, it exists in about 12%. Behavioral problems, anxiety is upward of 60%. In the average population, again, it's around 10%. So comorbidities are a lot of the issues we see in clinic with kids with Tourette syndrome. I'm briefly going to talk about medications because that's not why you guys are here. The main group of medications that we use, alpha agonists, that would usually be like a 10X or a clonidine. Those I personally use they're commonly used first line. They are blood pressure medications. They kind of can calm the kid down. We don't stop and start these abruptly because if you are on a high dose and stop suddenly, you can have really high blood pressure transiently. So we do warn that if you're on that for a while, it's not working, don't stop it without talking to someone. Antipsychotics. So the most common ones used would probably be Abilify and Risperdal. Those though they're actually a little bit more effective in terms of head-to-head comparison and tic severity, more effective than the alpha agonist, the side effect profile can be pretty daunting. You do have to do some lab testing periodically. You can get gynecomastia, which is a development of breast tissue, which a lot of the boys are already getting teased sometimes for the Tourette syndrome. They also don't want gynecomastia, weight gain. Botox is something that more commonly used in adults. I have been trying to get it implemented here a little bit more, and it has been a little bit difficult. Topiramate is actually kind of an exciting, slightly more frequently used one recently. Head-to-head, it actually looks like its data is as good as around the antipsychotics. Now, Topamax is an anti-seizure drug. This one, I would use this in someone who has headaches and Tourette's. This is a very good headache medication as well. And it reduces tics by about 40%. So it can be helpful if someone happens to have headaches and tics, and I've seen it be pretty effective occasionally. Non-medication, I'm just going to briefly talk about this. So CBIT, Comprehensive Behavioral Intervention for Tics, is a Yeah, I might even just like skip this, but we will have so much on this later. The reduction is phenomenal in tics. It actually is much better than medications, and the improvement is actually there whether or not you're on medications or not, which I think is an exciting feature of CBIT. So when I have someone in, they're new to this, what do I tell them? What do I tell the average family or kid that's in my office? So avoid escapism. So this is, there's this delicate balance, I think, between making accommodations for kids with tics and Tourette's and avoiding escapism. Escapism means you get out of things, or you don't have to do things, or you get certain favors because of your tics. And you want to avoid that because that's creating that positive dopamine. You're getting some sort of benefit from doing this movement, and that's going to actually habituate that even more. So you will hear families say, like, we don't have them, if they're having a really bad tic, they can have dinner in their room, and that's actually not okay. They can take a break. So that's the accommodation, but they don't get to be excused. They still have to complete the same amount of homework, the same tasks, but do they get certain things to allow them to make that a little bit easier? I think that's fine. We don't ever punish or shame children for tics. This truly is something they can't control. Telling them to actually stop or punishing that makes it much worse. And that negative reinforcement is still reinforcement. We want to avoid that. And I only threw number 3 in there because a lot of people will say, like, what diet should I do? And the answer is like any that's healthy. A variety of foods. Don't avoid any, don't go crazy. Just good old, whole foods. Try to minimize, processed foods, but we all should. So help find your way, for your child to relax. That's a huge one that isn't involving screens. So screens are actually very stimulating for children. They can be a little bit relaxing for adults, but the way that their brains are wired, they actually need non-screen relaxation time. Support groups are great. Ergo, Jeff. Children with tics should not be bullied. I would, Jeff can offer some education to schools as well. And they may need special education assistance, maybe like different seating arrangements, additional time for testing. But again, that's not, they don't have to do tests. They don't have to do homework. So they can maybe have some things set up to individualize their environment to like maximize their success. Okay, moving on to something. So 2 years ago, like fall of 2020, I remember one of my colleagues comes up to me and says, Chelsey, there's this funny thing. I'm in charge of all the referrals, and I have seen this huge increase in teenage girls coming with tics. What is that? And I was like, I don't know. And this is when I started to take on this role as doing about 25% of my time in tics and Tourette's. So we had a huge uptick, pardon the pun, in kids with functional neurologic disorders, namely teenage girls, most particularly. So a functional neurologic disorder is someone that has neurologic symptoms where the cause or the etiology to those symptoms is not neurologic, it's actually psychological. So the age of onset is usually middle adulthood, but actually can affect kids as young as 6. But I would say frequently it's more in the young adults, teenagers that we find it. Sex ratios, females are affected more often than males in both children and adults. In large studies, the percentage of females is 60 to 90%. So yeah, sorry, those two statistics kind of argue against each other. In younger kids, it's similar in sex, but the older you get, it's more likely to be female. So this is a study, is this one? I'm forgetting where this one came from, but so this was one of the first ones in July of 2021. Yes, I think this is the one out of Calgary. This was phenomenal and helpful. And I would recommend looking at this. You don't need to get in the nitty gritty of this, but basically they saw that, we are seeing this huge increase. They are females. This is actually an adult center. So they had young females come in, which for us in pediatrics, this is like teenagers, older kids. And they would have an abrupt onset. So typically when you ask someone with tics and Tourette's, you'll say, when did your tics start? And the parents will say, I don't know, first grade? Was it first or second grade? I don't know. You did the sniffing thing, maybe first grade, maybe summer. I don't know. In kids with functional neurologic disorders, they were finding that, like, we would say, when did it start? And they'll be like Thursday at 2 o'clock. It was a sudden, abrupt, or like, and maybe not even a day and a time, but like that week of, like finals or something. There was a sudden, they could tell you to almost the day that it started. And whereas most kids, as we talked about, will start with having something kind of small in the face, it goes away, then something new comes up in the face, it goes away. These kids were having abrupt onset of multiple tics. So, and they were having very big tics. So most tics start in the face and they one at a time, they come and go. Whereas these kids were having like chest thumping tics. They were like stretching, like huge, big movements, huge, big vocalizations. They would have many tics all at once, starting on one particular day. So they also tended to have higher scores on all mental health symptoms self-report measures. And the suspicion was that this may have been related to COVID-19, perhaps being on screen time too much, perhaps isolation, perhaps increase in depression. It was hard to say exactly what drove this. This came from the Tourette Association. I think it came out in November of 2021. And again, they kind of compared side to side. Typical tics, again, male in the majority, 4-to-1, childhood onset, age 5-6, simple tics in onset, that's the early on they've had simple tics, and they have a premonitory urge. In functional neurologic disorders, we are finding they were female in majority, teenagers onset, so like 13, 14, 15, they would have very elaborate tics at the onset, and they often describe no premonitory urge. I like this one a lot, and I think we got a little weird about this one at one point in clinic, but there was a panel that they took movement disorder specialists and actually had them watch TikTok videos where the hashtag was Tourette syndrome, and they found that the frequency with which people were having coprolalia, self-injurious behaviors, though those things are things we infrequently find in kids with typical tics, this was like almost the majority of these TikTok videos. I will say, like, having now seen this and now having my own Instagram and now following some of these people, it's to the point where I sometimes I wonder if these people don't have functional or neurologic disorders themselves, but I worry that what they have are fictitious, and that they now sell hoodies and stickers, and they consider themselves neurodiverse, and they're doing these videos that to me are not they do not meet the typical tic or Tourette pictures. So it is a really unfortunate thing. And while a lot of parents, when I talk to them and say, I think that this might be what it is, they'll say, well, they're not on TikTok, they're not on YouTube. And at this point, especially this far out, I would say it's so pervasive in high school and middle school that I don't even think you necessarily need to have a social media account to be exposed to this, because it is becoming so common. And so as opposed to asking what social media account do you have, I'll say, who have you seen that's done this? And they'll be like, oh, my friend, this friend, Jackie or something from class. And and this quote at the bottom is a good takeaway. We believe this to be an example of mass sociogenic illness, which involves behaviors, emotions, or conditions that spread spontaneously through a group, meaning teenage girls more particularly. I've seen it in a boy. So again, this is kind of the same thing. This is the second study that looked at it, and they said, whereas coprolalia and self-injurious behaviors, there's a lot of chest thumping and like hand clapping. That's a really common one in this group of people. Though self-injurious behavior and coprolalia, which is again the obscene language, is only infrequently encountered in typical tic disorders. They're present in the overwhelming majority of TikTok subjects, and I cannot, having watched this, I got TikTok on my phone, and then I watched a few of these, and I couldn't do it anymore, so I had to take TikTok off my phone. I also didn't want to be a 37-year-old with TikTok, so there's that too. Too old for TikTok. So what do we do if they come in to the clinic and I say, well, this is what I see in a typical tic patient. I don't think that's this. You had a sudden abrupt onset. You ended up in the emergency room the day it started. That's also a red flag to me as well. Why, the difficult thing is, so I don't have a test. Like, I don't have a needle I can put in your arm. I don't have blood work I can do. I don't have an image I can do to your head to tell me what is a tic and what is a functional neurologic disorder or functional movement. I don't have that test. So I just hear the story and I say, wow, this doesn't really fit like this. Why do I bother to go ahead and say, this is a tic and I think this is a functional movement? Because receiving a correct diagnosis will avoid inappropriate medical interventions. Functional neurologic disorders require a different therapy. They respond to CBT, not CBIT. Now, CBT is a little bit more of like a typical talk therapy. It's cognitive behavioral therapy, how your thoughts and behaviors affect your emotions. So it is a long road, but there are studies to say that And so these kids sometimes need SSRIs. And again, medications for tics and Tourette's aren't helpful. So if you're on Abilify or Risperidone, you're taking medications that have side effects that aren't going to help this disorder. So the hard part is that well-intended parents, well-intended responses by parents or teachers may worsen symptoms. For example, excusing someone from chores with functional tics or over-focusing on these may provide unintentional reinforcement, causing the symptoms to continue. So you'll see, and it's so hard as a parent, how do you watch your kid have these like self-injurious behaviors, cursing, hitting themselves, throwing themselves on the ground, spitting, those types of things, and not do anything, but it actually kind of is the right way to go about things. And that is not a talk for now. So why do we identify functional neurologic disorders versus Tourette syndrome? So why do I try to tell it to them when I can, though it is a very hard diagnosis to frequently talk about, is that the longer time it takes before you're diagnosed with a functional neurologic disorder means your outcomes are likely worse. There's actually a study out of, I think, just the Journal of Pediatrics that looks at kids with somatic complaints, so some of these functional complaints. If one parent buys into the diagnosis, the outcome of the child is better. So funny is you don't need to get two parents to buy in, but you need at least one parent to say, okay, I can see how this is now functional, and then they can kind of move on from that, and the kids actually do a lot better. So this is why we tend to try to give that diagnosis when we can. What's interesting too is a lot of people, will kind of push back on this diagnosis, but there was a review of 27 studies with a total population of 1,466 patients. The frequency in which we misdiagnosed a functional neurologic disorder was only 4%. So if it's functional, we're usually quite correct. Interesting as well as emotional disorders and personality disorders are not consistent predictors of functional neurologic disorders or outcomes.
So with this next talk, we're going to talk a little bit more about comprehensive behavioral intervention for tics. We're going to talk about a little bit more about what it is exactly and how it works. So before I start with that, a little bit about me. I graduated from University of Southern California with a master's in occupational therapy. I completed the CBIT course in 2021 and received my certification early this year. I have experience as an occupational therapist in neurology, sensory processing, and feeding. And I am, as Jeff said, one of the two occupational therapists in the integrated Tic Clinic here at Children's Hospital, Colorado. So some objectives for today. Hopefully by the end of this talk, you'll be able to learn the rationale behind CBIT treatments, name the two overarching components of CBIT and what goes into each component, learn a little bit more about who is appropriate for CBIT, and learn about the effectiveness of CBIT. So before I get going talking about CBIT, I know Chelsey mentioned this a little bit too, but I think this is an important distinction to make. CBT versus CBIT. We have seen kids in clinic who say, well, I've tried CBIT and I didn't think it was particularly helpful. And when we got to asking questions, it turned out that it was actually CBT or cognitive behavioral therapy. So I wanted to kind of point this out to show the differences as well. So what is cognitive behavioral therapy? Well, it's a type of treatment utilized by mental health professionals, psychologists, social workers. It's used for a variety of disorders. There's some listed here, such as anxiety, depression, addiction, eating disorders, and many more. And as Chelsey mentioned, it's focused on changing thinking and behavioral patterns. This is in comparison to comprehensive behavioral intervention for tics, which is a treatment that is developed for tic disorders and Tourette syndrome. It does draw on some cognitive behavioral therapy principles, but it has many other components as well. So for the sake of this talk, I'm going to be referring to comprehensive behavioral interventions for tics as CBIT. All right, so treatment for Tourette syndrome and tic disorders, well, it's not needed in all cases. If we have some mild cases, if your tics don't interfere too much in your day-to-day living, day-to-day life, then maybe you don't really see the need to pursue treatment, and that's okay. The Tourette Association of America has outlined 3 overarching treatments for Tourette syndrome and tic disorders. One of them, Chelsey discussed briefly, which is medications and pharmacology. The other one is what I'm going to talk a little bit more about today, is CBIT. And the last one we won't talk about today. It is used in very rare situations, but that is deep brain stimulation. All right, so an overview of CBIT. Well, there has been over 40 years of behavioral intervention for Tourette syndrome and tic disorders in the research. And finally, but there's nothing really systemic, any sort of treatment that was designed particularly for this population. So finally in 2001, the Tourette Association of America and the Behavior Sciences Consortium came together and they developed CBIT. It was developed for children and adults ages 9 years and above. The goal of CBIT is to learn effective tic management skills. The goal is not to cure Tourette syndrome. And the general structure is 8 60 to 90 minute sessions over 10 weeks, and then you can do booster sessions as needed. So what is the rationale for CBIT? What do we know about tic disorders and Tourette syndrome that is the foundation of this treatment? Well, as Chelsey mentioned, we know that tics are neurological in nature. We know that these are not things that you're necessarily doing on purpose. But we also know that tics are highly impacted by internal and external environmental factors. We know that tics wax and wane, and we know that they are preceded by an uncomfortable feeling or premonitory urge. And the last thing we know is that tics, this premonitory urge and tic cycle can actually create a negative reinforcement cycle. So let's take a look at that. What is this negative reinforcement cycle of tics that we see? Well, most tics, you have a premonitory urge, a sensation, a tingling, an itch, any sort of kind of something that doesn't feel right that precedes the tic. Usually it's found in the region of the tic. So once we feel that urge, then we know that we need to tic to get that relief. So we have this cycle where the relief in and of itself actually reinforces the tic. So that's that negative reinforcement. So when CBIT was developed, the idea was, where do we focus in this cycle to do an intervention? And the idea is that if we can focus on this premonitory urge and prevent this subsequent cycle from happening, then we can help better manage your tics. So this slide is just kind of an overarching slide to show all the components that go into CBIT, and I will go into each one in future slides. But there are two major components of CBIT. One of them is habit reversal training. That includes awareness training, selecting your competing response, and identifying a social support person. The other component is function-based intervention. So that is where we look at the environmental impacts on your tics. And in doing this, we look at the ABCs of behavior, and we also have identified some relaxation training that can help manage your tics as well. So let's get into this. The first part of habit reversal training is awareness training. So each week, you will identify a tic for that session. So you focus on one tic per session. And in the session, once the tic has been identified, you really practice that tic repeatedly with your CBIT therapist. And that is so that you start to learn all the body parts and systems involved in your tic. In what order do they occur? Start to recognize that premonitory urge if you're not already recognizing it, and where it is exactly. From there, you do some exercises where you start to signal, usually it's like raising your finger, when the tic just happened, or ideally, when it's about to occur, when you feel that premonitory urge. So all of this is very important because, as you can imagine, you need to know your tic, what the urge feels like, in order to do the subsequent steps of habit reversal training. So sometimes, tics don't necessarily happen every hour. So if that's the case with a tic we're working on, we might even choose some activities to trigger your tic. So if we know that the tics happen while you're playing video games, for example, we might incorporate some video games in sessions so that we can do some of this habit reversal training. The next component, once you've got that awareness and you're about 80% in being able to detect when it's about to happen or when it's just happened, that's when we go into this competing response training. So the competing response is a action that we do once we feel that urge that helps eliminate the tic from happening or prevent the tic from happening. So there are 3 rules outlined in CBIT to help select a competing response. The first rule, and you'll see this in a video coming up as well, the first rule is it has to be physically incompatible to the tic, which means that it has to prevent the tic from happening. The second rule is it has to be less noticeable than the tic. This is usually the case, it's not always the case. And the last one is it has to be held for 1 minute and it has to be able to be done anywhere. So once we kind of talk about what we think would be a suitable competing response, we might try it out, we might practice it, see if it truly does prevent the tic from happening. And if that's the case, then we will, again, do things to trigger the tic to practice the use of the competing response in session. So this is taken from the CBIT guide, which I'll show you a little bit later. These are just some common tics you might see and some suitable competing responses. So for example, if we have a facial grimace tic, we might choose to purse our lips as a competing response. If we have a head jerk tic, we might tense our neck muscles or lower our chin. Any sort of wrist movement tic, we might put our hands on our legs, maybe even squeeze if we feel like it's necessary. Leg lifts, we might push our heels into the floor. Tongue clicking, you might want to push your tongue to the roof of your mouth or maybe do some controlled breathing. And with phonic tics, we will want to do some controlled breathing. So this is where we really want to kind of focus on what is the breathing pattern of the phonic tic, because the breathing pattern of the competing response should be the opposite. These are just some examples. They should be taken with a grain of salt because really part of the competing response training in CBIT is following the rules and your child learning to do, come up with their own competing response on their own. But there are some, suggested options available if needed. All right, so I'm going to show a video of what the competing response selection looks like. In this video, you actually see the therapist is Douglas Woods, who is one of the founders of CBIT. So let's take a look.
Ty, you did a great job coming up with the definition and description of your head jerking tic, okay? But what we're going to do now is to try to teach you an exercise that will help you stop that tic, all right? Because ultimately the goal is to try to get a little bit of control over that head jerking tic. So what I'd like to do is to come up with an exercise that you can do that will help you control the tic. And the exercise that you choose has to meet 3 rules, okay? The first rule is that any exercise that you choose has to prevent the tic from happening or at least make the tic harder to do, all right? The second rule is that the exercise that you choose has to be less noticeable than the tic, right? So it can't be as obvious as the tic. And the third rule is that you have to be able to do that exercise anywhere at any time for a minute or until that urge goes away.
Okay.
Okay. So again, the 3 rules: it prevents the tic from happening or makes that head jerking tic harder to do.
Okay.
It's not as noticeable as the head jerking tic, and the exercise you choose can be done anywhere and it can be done for a minute or until the urge goes away.
Okay.
Whichever takes longer. So if you think about your head jerking tic, can you think of an exercise that might meet those 3 rules?
Maybe like holding my head like this.
Okay, so let's think about that. So if you hold your head like that, let's see if it meets the first rule. Can you hold your head like that and still do your head jerking tic?
A little bit.
Okay, so it might not meet that rule. What's more noticeable, the head jerking tic or you going like that?
Me going like this.
Maybe it depends, because a head jerking tic can be kind of noticeable. Can you do that anywhere?
That's kind of where it might be noticeable. Like in the mall, if I'm just walking around and going like this.
Yeah, that might look kind of strange. Or what if you're, pitching in a baseball game?
Yeah.
That might be a problem, right? Okay. or you're holding your bat, you're up to bat.
Yeah.
You know, that might be a problem too if you like, jump up to do it. Okay, so that one has some problems maybe.
Yeah.
What, you know, one of the things we commonly do when we have a kid with a neck jerking tic is we teach them to do this. We have them drop their chin a little bit and hold the sides of their neck tightly, not with their hands, but just to tense their neck slightly, not too much, but just to tense their neck just a little bit, right? So not too tight. So once you do that, okay, let me check your neck. Okay, is it really tight? Okay, good. Just a little bit tight and hold your neck down. Okay. And so once you do that, if you hold that position, can you throw your neck back or not?
Not really.
Okay. What do you think's more noticeable? Your head jerking or what you're doing right there?
My head jerking.
Right. Okay. So now can you pretty much do that anywhere?
Yeah.
So can you hold that for a minute?
Yeah.
Okay. If it's too tight, if you're holding it too tight, then don't do that because we don't want you to be able to hold
so what I really like about this video is, I'm guessing this is probably session 1 or session 2 of CBIT, but you notice that Douglas gives the child the tools he needs to determine these things on his own. And that's really the idea of CBIT. It's not that you need a CBIT provider at all times with all tics. It's that at the beginning, we'll scaffold it, so we might be a little bit more hands-on, and then by the end, you know, we're really taking a step back and allowing the child to lead the intervention.
How you getting?
All right, so the last part of habit reversal training is an important part because, as you can imagine, 1 hour a week with a CBIT provider is not enough to see any sort of improvement with tic severity. So identifying a social support person is a big component of this. That's usually a caregiver or a parent or anyone who lives with the child. The support person's job is to keep your the child or your child accountable. And the idea of this is that you need to overlap, meaning spend time with each other for about 30-minute segments, at least 4 days per week. It doesn't mean that you have to kind of sit and just talk about your tics for 30 minutes, but you can overlap, for example, at the dinner table or while watching TV at night. The idea of the social support person is to really keep your child accountable for doing their competing response exercises. So, and really you'll work more with this with your CBIT provider too. The idea is to keep it really light and positive, and not make it negative or like a punishment or scolding or anything like that. So really reinforce your child for using these competing response exercises. Hey, nice job doing your exercise just there. If you see that they're forgetting to do their competing responses, that's when you might remind them in a positive way. Don't forget to do the competing responses. And the idea of the social support person is really to be a coach and kind of, like I said, keep things positive. All right, so that was habit reversal training. That's one of the components of CBIT. The next component is this function-based intervention. And in this component, what we do is we learn how the environment is impacting your child's tics. We also start to identify strategies or changes to lessen the environment's impacts on your child's tics. And we might even choose some proactive strategies to manage tics in high impact places. So an example of this would be like, if I know that I tic a lot in Walmart, then I might do my competing response before I even sense the premonitory urge. Maybe do it in a systematic way. So every time I turn down a new aisle in Walmart, I'm going into this competing response. And that can help manage your tics as well. So when we look at the environmental impact of tics on tics, I like to use this ABCs of behavior model, which is a behavioral model used beyond tics, but in this case, it's been adapted to tics. The ABCs of behavior being that the antecedent is the A, what happens before or what may trigger the behavior. The behavior, the B in this case, is the tic itself. And the consequence, C, is what happens after, reactions that may reinforce the tic. So these are some examples of antecedents and consequences that have been identified for tic disorders and Tourette syndromes that can reinforce tics. So some antecedents, we have loneliness, stress, anticipation, such as anticipation of social events, fear or boredom. If you notice, all of those are internal states. Also, some things like sedentary activities like watching TV, video games, returning to school, loss of sleep. Then if we look at consequences, some consequences that have been identified include just the relief in and of itself, like we discussed, being aware of being observed, if you know people are watching you while you're ticking, escapism, as Chelsey mentioned, so being able to leave class, being able to stop doing homework because of your tics, receiving attention. So that can be either positive or negative attention, whether that's being told to stop, people laughing at you, people staring at you, or even being comforted because of your tics. All of this can reinforce your tics. And the last one is being asked to leave, which can happen frequently at school. So these are just some examples. They're not going to happen. Every child, every tic is different. So really part of this component of CBIT is sitting down with your CBIT therapist and identifying what factors really impact you or your child's tics. All right, so then once we've identified environmental impacts of our tics, there is some relaxation training that is worked into CBIT. There are 2 exercises in particular that have been identified that you practice with your CBIT therapist. One of them is diaphragmatic breathing, and the other one is progressive muscle relaxation. So diaphragmatic breathing is that slow, deep breathing from your diaphragm, and the progressive muscle relaxation is where you tense and release groups of muscles for a period of time. These can be used as part of your intervention for the functional intervention. So for example, if I have more tics when I'm anticipating a big event like a play or something like that, then I might go into my diaphragmatic breathing before the play to help manage my tics a little bit better. Progressive muscle relaxation can be really helpful for bedtime, to help get ready for falling asleep and help manage tics in that way as well. So studies have shown that these exercises, when used within the CBIT treatments, can actually help decrease tic severity over time. When used alone outside of CBIT, they don't show any changes on tic management. And this last bullet point I had to include because I'm an occupational therapist, and what we tend to do as occupational therapists is really do sensory regulation curriculums as well. And these work really nicely in here in the function-based intervention. There are studies that show that the alert program, which is, how does your engine run? Too fast, too slow, just right. Using that with patients with tic disorders can actually help decrease tic severity. And then there's this other program that I really recommend you guys check out. It's called the Leaky Brakes program. It is like a regulatory program that was designed specifically for people with tic disorders and Tourette syndrome. And that, I believe, is from the Ontario CPRI. So check that out as well. But these are both things that we integrate into our functional intervention if needed. All right, so now that we've gone through all the components of CBIT, let's take a look at what a typical session might look like. This can vary provider to provider, but this is just kind of a general idea. The first thing that we might do is check in with our social support for the week, talk to the child as well. So how did this last week go? How did it go doing your exercises? Where did you find that you were able to catch it and do your exercises? Where do you feel like it was challenging? Do you feel like the competing response was helpful? Do we need to make any changes, etc.? So from there, each week and each session, you fill out a form. That's the tic hierarchy and distress scale. And that is essentially how bothersome are your tics that week. So each week you give it a numerical rating. This is really to help track, to see how our tics are doing, but also to help identify, you gave this tic an 8. Maybe this is a good tic to focus on this week, 8 out of 10. So that is usually towards the beginning of the session. From there, once you identify your tic, you go right into the habit reversal training of the new tic awareness training, selecting the competing response. Then you go into the functional intervention for that tic. Where are you noticing you're doing it? What can we do about it? And then the homework will typically look like that social support, so really overlapping with your social support person, that week, and also identifying some changes you want to do that with that functional intervention. Like I mentioned, the Walmart thing. So, okay, maybe every time I go into Walmart, I can go into my competing response every time I go down a new aisle or something like that. So because I'm a visual person, I kind of wanted to lay this out. I know it's not the most normal of frequencies, but sample CBIT timeframe. As you can see, the first 6 sessions are weekly, and then the last 2 sessions are spaced out every other week. The rationale behind this is because, like I said earlier, the idea is that your child is slowly getting more and more independent in tic management as we go through CBIT. So by session 6, 7, 8, you know, really your child's taking the reins in terms of how they're going to select the competing response, what functional interventions they're going to do, so that, you know, when we're done with CBIT, should new tics occur, or maybe your child has more than 8 tics, they have the skills needed to proceed to manage their tics as they go on. In this case, I did throw an example booster session 9 on about 3 months out, and that is, you know, you can do that as needed if you feel like you want to touch base. If you feel like I can't really think of a good competing response for this tic, etc. So there's a lot of flexibility here. You don't necessarily need to stick to this time frame, but this is the one that was outlined by the people who developed CBIT. All right, some important notes about CBIT. CBIT is not suppression. So suppression is often tedious, and as Chelsey mentioned, can lead to just needing to let go of tics later. As part of the competing response, remember, we're looking for something that is physically incompatible to the tic. So we're actually intervening to prevent the tic from happening. Another important note is it's not linked to the development of new tics. The competing response has not been shown in any research to then turn into a new tic, if that makes sense. It is highly recommended to treat or control any comorbidities before starting as best you can. You know, we know that there, like, anxiety symptoms can exacerbate tics, so really coming at it from a, you know, getting that CBT if needed or anything like that to help support any comorbidities is important. It does, and this is why, it does take a lot of effort at first. I mean, your child may tic, do you have any tic that can happen hourly? So imagine if you have a certain tic 4 times an hour going into that competing response throughout the entire day. So the idea of CBIT is that we're trying to do our exercises all day long, and then that social support overlap is really just there to keep us accountable. So it does take a lot of effort at first, but it should get a little bit easier with practice. And like I said, it does teach independence in tic management. So the idea is that you don't need a CBIT therapist in the future. And the timeline is flexible depending on each person. So if you only have 4 tics, maybe you don't need all 8 sessions at first, for example. All right, so how effective is CBIT? Well, the research shows that about 52.5% of children had significantly improved tic symptoms with CBIT. As Chelsey mentioned, this is about the same rate, if not better, than medication, with, of course, less side effects. The research does show that these children who did show improvements sustained that improvement over 6 months in about 87% of cases. So we know that it can help improve tic severity, and that improvement is sustained over time. And the last thing I wanted to point out, because there still aren't that many CBIT providers out there yet, the research shows that it's just as effective over telehealth. I personally have done it over telehealth, and I actually think out of everything that we've all had to do over telehealth recently, it lends itself very nicely to a telehealth model. I think there's benefits to being in your house, in fact, where you might be able to access some of these things that trigger your tics a little bit easier. So if you don't live nearby a CBIT provider, don't worry, because it is very effective over telehealth. So am I appropriate for CBIT? Well, like I said, we recommend to treat and control your comorbidities first. The research does show that untreated ADHD can show worse outcomes with CBIT. And the last bullet I think is really important. Your child's interest matters here. So if you as a caregiver really want your child to learn tic management, but your child doesn't care, then it's not going to be super effective. And there's nothing wrong with not caring. But really, if your child takes the initiative and wants to work on their tics or learn how to manage their tics, then they're going to be more appropriate for CBIT. All right, I did want to include this bullet point because, as I mentioned, CBIT was developed for children and adults ages 9 and above, but a lot of the Tourette diagnoses happen younger. So what about those kids? Well, there is CBIT Junior in development for children ages 5 to 8 years. It's a little bit different from regular CBIT in that there's a greater emphasis on parent psychoeducation. I believe the first entire session is just with the parents, not with the child yet, because really at this age, the parents are going to be key for success. There are some changes in the session structure. So I believe part of that competing response training, they have different cards of different movements your body can do. So for example, a head jerk, and the child it's kind of like a game, come up with the opposite movement of this, just to kind of gauge their readiness to do CBIT. And the exciting news is that the pilot study shows significant decrease in tic severity. So stay tuned. Hopefully this will be out soon. All right, Chelsey kind of talked a lot about this. I'm sure Kristen will talk a lot about this as well, but this is how can I help manage my child's tics? I think it's important to find a neurologist to follow your child for routine visits, especially if they're on medications, to see if any changes are necessary, if any further support is necessary. Find a specialist to support any comorbidities. So maybe find that counselor or psychologist who does cognitive behavioral therapy, maybe seek an occupational therapist for ADHD concerns, etc. Here I put if appropriate, because again, it depends on how motivated your child is, or if your child wants to pursue CBIT, then that is definitely recommended to find a CBIT provider. Consider the ABCs as a parent. What am I doing that can be reinforcing my child's tics? And again, if you do pursue CBIT, you will go into this with your provider in great detail. This bullet I think is really important, especially for the Tourette syndrome population. Support your child's self-advocacy. I think the best thing they can do is learn to feel comfortable to talk about their diagnosis, talk about, I can't control this. The best thing you can do is just to ignore this, talk about it with their peers, with their educators, with people, anyone who asks. Talk with school about getting an IEP or a 504 accommodations if necessary, really to help your child excel academically. And then Tourette.org has so many great resources and information. They have free toolkits for educators that I frequently use, free toolkits for healthcare professionals. There's just so many great resources on there. So I highly recommend you check that out if you haven't already. There's a provider list, etc. And I did want to put this photo up here of this book. This is the manual, the parent workbook for CBIT. So if you are considering pursuing CBIT services, I do recommend that you purchase this book if possible. You can find it on Amazon or Barnes & Noble, or you can find it online pretty easily. And in this book, they'll kind of talk you through each session. They'll talk you through CBIT. There's some worksheets for your child to do. Yeah, so it's a really nice resource to have as well. All right, so let's say I want to pursue CBIT. How do I go about doing it? Well, there are two options. One of them, we have it here at the hospital, Children's Hospital Colorado. If you want to pursue it here, you can call the occupational therapy schedulers at 720-777-6611. When you talk to them, ask for CBIT treatments. And I have this bullet point on here for your own reference. Here at the hospital, outside providers, CBIT providers might bill differently, but we bill it as occupational therapy services. So if your insurance covers occupational therapy, it should be covered. There are also other Colorado CBIT providers available to you. Our wait list is usually around 6 weeks. It depends on your flexibility with scheduling as well. So if you want to pursue other Colorado CBIT providers, that's great. There are some great providers in the state of Colorado. So that's where you would contact the Colorado TAA at coloradotaa@gmail.com and ask for a list of providers for CBIT.
So I'm Kristen, as Jeff said. I'm an occupational therapist at one of the therapy cares here at Children's Hospital. I have a background in sensory processing, autism, ADHD, working with kids individually as well as in groups, and also kind of on the self-regulation and social skills piece too. But let's get a little bit more into what is OT beyond just CBIT. As Kate kind of highlighted, with CBIT, that we focus a lot on those vocal and motor tics, or we talk about the top of the iceberg. I love this from the Tourette Association, this visual that talks about vocal and motor tics are really just that top of the iceberg. And below, hopefully you guys can see this at home, we see a lot of other co-occurring, whether it's diagnoses or just factors and symptoms, whether it's social communication difficulty, impulsivity, sensory processing issues, executive functioning, difficulty with transitions, rage and disinhibition that kind of goes with that self-regulation. So today I'm going to kind of focus more on some of those things below the iceberg, because as Kate kind of highlighted, and as you may be gathering, both sides of the iceberg really impact our day-to-day participation. Our tics can impact everything below, and everything below can also impact our tics. So my two things for you to learn today are defining kind of what is occupational therapy and what is my role to help with individuals with Tourette's outside of CBIT, and then also just a little bit on how you can access these services. So what is occupational therapy? I really like this quote from AOTA. It says that occupational therapy practitioners are experts at helping people perform the occupations they need and want to do every day. Thinking about need and want, I think, is very important, and I highlight that with a lot of my patients. So what do we need to do or want to do every day? As an OT, we think about activities of daily living. That's like our self-care tasks, getting dressed, taking a shower or bath, eating, brushing our teeth, brushing hair, those kinds of things to take care of ourselves. Beyond that, especially if we want to live independently, there are instrumental activities of daily living, or those IADLs, cleaning, cooking, household management. I also think about navigating the community, whether it's driving or taking public transportation, things like that. Rest and sleep, which is a big one, and we see definitely typically impacted with individuals with Tourette's or tics. Education, participation in school, handwriting, that's another big area that we'll get to. Work, holding a job, finding a job. Play and leisure, it's always important for all of us to have things that we want to be doing for fun, whether it's organized activities or just informally spending time with friends, which is that social participation piece, which can definitely be tricky depending on the individual. And as you can see, there's lots of occupations that we all need to do or want to do every day. But beyond occupations, as an OT, I also think about our performance patterns and skills. So that's individual skills individuals have, whether it's our fine motor, gross motor, visual motor, coordination, balance, and strength. Those all feed into our ability to complete a task. For example, like if you think about tying your shoe, if you don't have the coordination skills or the fine motor skills with your hands, it can be very tricky to make those little knots and get the string in the right place. And then also if you think about the executive functioning skills that go into that, such as problem solving, paying attention, sequencing. So if we even go back to that shoe tying example, what is the sequence of tying a shoe? What if I get a knot in my shoe or it gets stuck? This is like a very basic example, but something I think that can highlight nicely, like we have this occupation that may seem simple, but depending on the individual, or if you're having a tic while you're trying to tie your shoe, that'll of course make it a lot more difficult to coordinate it, or even sometimes even attend to the task. Beyond that, thinking about emotional regulation, I think that's a big one. Maintaining that, I always call it that just right feeling, that ability to kind of stay calm and focused. And then sensory regulation, which Kate kind of highlighted on, and we'll get into more later, but sometimes we're more sensitive to certain types of sensory input or less sensitive or unaware of certain sensory input. And all of that is absolutely important to think about when it comes to thinking about participation in occupations. Beyond that, those personal factors, values, morals, the context. Is it important for you to tie your shoe, or will you just wear a shoe that doesn't have ties? Also, some people might just be like, I don't even really like any shoes with ties, and that's fine too. So as an OT, we definitely have to think about that. I absolutely think about that. Like, I'm not going to work on teaching someone to tie a shoe if they have no plans or had no interest in wearing shoes that tie, as well as those mental health factors. I think that's a big one here, as we've seen some of those co-occurring and comorbid conditions that we frequently see with tics and Tourette's. So this, I think, kind of highlights everything really nicely. So you see around the outside of this diagram, all of those occupations we think about each day that we are wanting to do or need to do. And then in the center, it's really like all those factors that make us who we are. And as an OT, we get to kind of think about this whole big picture and how that we can support individuals for the occupations and meeting them kind of where they are. So now we're going to go through and kind of think about how occupational therapists can work with individuals with tics and Tourette's. And I'm going to do my best to highlight all these areas, as Jeff mentioned. Please add in any questions. I think I could spend 10 plus minutes or even a presentation on a lot of these individual sections. So I'm going to do my best to just kind of give a nice little overview of them. So as I kind of mentioned before, we're really thinking about this pyramid or this iceberg, thinking about how everything below it impacts those tics on top, and our tics impact our participation in everything below it. So we're really going to focus on that, supporting what is under the water in the iceberg. One big thing that we will just start with is the self-regulation piece. I think that's huge. Awareness of emotions, knowing how to change regulation, and implementing strategies. That's kind of the three pieces of self-regulation. And even with CBIT, you have to be aware of your tics. So some may even talk about how like self-regulation work might be important prior to CBIT if we're not aware of our emotions, or if we have increased episodes of rage or getting upset, things like that. And as an occupational therapist, Kate kind of mentioned some of these, but I just have some visuals for them. So the beaker is from that Leaky Breaks, which is a free kind of curriculum available online, but it's thinking about what fills our frustration beaker. As well as the engine speed is in the middle, and that's kind of finding that just right. Some things make us feel fast, some make us feel slow, and something makes us feel just right. For older kids and teens, I love using the zones of regulation too, thinking about kind of what is that green zone, that happy, calm feeling feel like. Maybe where do our tics make us feel? Do they make us feel more frustrated or more sad? And being aware of that is super important, so that then we can figure out like, what can I do to help me get to the green zone or get to that just right place? Whether it's like taking a deep breath, or other sensory-based strategies, which we'll get into too. That first piece is kind of figuring out what is that just right feeling or that green zone feeling, and what is kind of filling up my beaker or putting me kind of over the top. So along with self-regulation, as an OT, I look closely at sensory processing. So we have 8 senses. The 5 that I always say you learn about in school are eyes, ears, taste, smell, and touch. But then there's also 3 more that are pretty important to our daily functioning. Our vestibular sense, which is our sense of movement and balance, which really helps us navigate the world around us. Our proprioceptive sense, that's our muscles and joints, helps us know where we are in space. Again, teams up with our other sensory systems to safely navigate the world around us. And the interoceptive sense, which is internally, are we hot, cold, do we have to go to the bathroom, anything like that. And of course, if we think about these sensory systems, you could easily see, or some of you maybe even be noticing like, oh yeah, loud noises kind of fill up that beaker, or, you know, tags in my shirt fill up that beaker, or make me kind of feel fast or into that yellow or red zone and just put me in not a just right place. So as an OT, we kind of work on thinking about that, because we think about our sensory systems in 3 ways. Being over responsive or under responsive, or kind of that seeking, or what we call modulation of senses. Motor based, so controlling our body, core coordinating our movements, and then discriminating different senses, hearing our name when it's called in a noisy room, things like that. So as an OT, we really dive into each of those sensory systems and think about how that impacts our day-to-day participation. I really like thinking about it like a pyramid. And as you see, all those sensory systems are at the bottom or the foundation for our day-to-day functioning. And then, I don't know if you can see it, but at the top is like academic learning, daily activities, behavior, kind of as we move up, we get into more of those self-regulation and occupation-based participation. So what do we know about sensory processing specifically for individuals with Tourette syndrome or tics? We know that it is more common to be over-responsive or oversensitive to sensory input. We also see that too much sensory input or too little can increase tics, whether it's like being somewhere that's dead silent, we see an increase in tics, or somewhere where it's like very noisy, very distracting, lots to look at. So being aware of our sensory processing can impact how our tics kind of wax and wane. We also see sensory processing differences in individuals with ADHD and OCD, or it can lead to increased anxiety. So what is OT's role? If you haven't gathered it already, with sensory processing, it's a lot of that awareness and using it to support self-regulation, or using it to figure out what can help us calm down, what can help us feel just right, as well as trying to support some of our senses to process information a little bit more smoothly or appropriately. The next area that I think is super important that we see commonly in individuals with tics and Tourette's is executive functioning, whether it's organization, time management, sequencing, planning ahead, even inhibition. We see a lot of challenges with executive functioning in individuals with Tourette's and tics. I didn't necessarily pull like a percentage because kind of as Chelsey mentioned, like every study you read could have a different percentage of what percent of individuals have executive functioning difficulties, as well as like what I was mentioning before, we see higher difficulty with executive functioning for the individuals who have other co-occurring conditions, whether it be ADHD, OCD, or anxiety, or other conditions. So as an OT, some things that we like to use are schedules and organizers, some file folders, some color coding, using some timers. This is like a visual timer I like to use for younger kids. Even I love using timers on phones or alerts and calendar features on phones, especially when we're working with teens and a lot of them have their own phones they use. I like thinking about this get ready, do done up in the corner. So getting ready, what do we need for a task? What are the steps to it? And what does done look like? We find with individuals who have difficulty with executive functioning that that done piece can be challenging. I think this is a perfect example of the like college dorm room that's really messy versus really clean. And I'll even sometimes use pictures to show like, this is what done looks like. When your room's clean, it should look like this. Because I think it's pretty common that we'll see kids and they'll be like, well, I think I am done. And the kitchen's a mess and all the dishes they just use are out. And it's like, well, you maybe made a sandwich, but are you really done with the whole task? Using checklists or daily routine visuals is another great one for kids, especially some younger kids respond really well to that. And I always talk, especially with teens and older kids, that like these are things that grown-ups use, like their grocery list or their to-do list for the weekend, or a calendar to help them keep track of dates and things. That these are some pretty accessible features which are awesome, and it's more just about figuring out how to use them and what works for each individual. Thinking about specific daily living tasks, I talked a little bit about daily routines. Another one I like to talk about is brushing teeth. Sometimes individuals with tics have a hard time brushing their teeth because they'll have an arm tic while they're trying to brush their teeth. So thinking about when is the best time to brush our teeth, or especially if you're working in CBIT, you can work with your CBIT provider of using that competing response while brushing your teeth, or maybe right before or right after, as well as like what other things will help your body feel calm and just right to brush your teeth, to see if we can make that task a little easier. Another one is kitchen tasks. I had one patient from clinic who was saying, oh yeah, I used to not use knives in the kitchen because I didn't know if I was gonna like throw them or drop them, and I was very unpredictable with them. Or same thing with glass dishes, like, oh, I just dropped glass dishes on the floor when I was walking, things like that. So thinking about modifications we can use, as well as thinking about like our routine, or is there a certain time that it might be better, or could someone do part of the kitchen task for us? Same thing with safety during driving. Or with employment, sometimes it can be about advocating to your employer, which we'll talk about a little bit more. Education, this is a big one, and I think I touch on this a lot in clinic as well as with the kiddos I see individually. Dysgraphia and handwriting challenges are very common for individuals with tic and Tourette's. We see that, if you can kind of see the jumbled writing on the side, dysgraphia is commonly like not using writing on the line, smushing letters together, reversing letters, things like that that can make work really hard to read. So we can think about other strategies, such as some individuals respond well to learning cursive, or just advocating for them to being able to type in class or use a voice to text software for assignments, and changing and making accommodations that it doesn't necessarily have to be handwritten, or just a portion of the work is handwritten. So thinking about those, we know that individuals with Tourette and tics have not as good visual spatial organization and visual perception. And that's what really goes into writing when we're trying to space out our work and get it on the lines, get it neat, those kinds of things, as well as planning and remembering. One study was talking about how some individuals with Tourette's don't do very well when they have to listen to their teacher and then write their work down. So can we get an accommodation that they get their work in writing, or have someone that they check notes with after class, things like that. As well as OCD can definitely impact schoolwork. If I have to keep erasing my work until I get it just perfect and can't get it just perfect, that's another one where I like to think about like typing skills, and is handwriting the thing that we need to do or not? And that's where we think about going back to those client factors and context. What is important to the individual or the family? Is handwriting important? And we need to figure out what kind of paper or things could support handwriting, or can we just move to typing and that'll be okay? Another big one for school is attention. So being able to sit still in class and pay attention. A big thing that we think about with individuals with Tourette's and tics that can be helpful is classroom seating, is sitting in the front or on the side of the classroom better, or in the back, so that they don't feel like as many people are watching them if they're having tics, or if they're on the side by the door that they could step out if they feel like they need to, with the idea that they are returning, kind of like Chelsey was talking about. We don't want to support the escapism, but this is where we can talk about some nice accommodations that can support success without supporting escapism, for sure. Or giving them movement breaks during the day, differential seating, sitting on like something that moves a little. Chewing gum can be a great one too, that can help with attention. Homework management and organization, that kind of goes back to some of the executive functioning pieces, some of those planners, special folders, color-coded things, stuff like that. We also can support as an OT. So there are also OTs in school systems, and they can help with IEPs and 504 plans. So an individualized education plan, or IEP, or 504 just help provide specific accommodations for students so that they can be more successful in class, whether it's extended time for tests, extra support, checking notes with a peer, using electronic notes, certain breaks that if they're appropriate, those kinds of things that can be hugely helpful to success. Another big piece as an OT that I think about is how we can educate teachers. Staff perceptions are huge. Some teachers don't know a lot about Tourette syndrome or tics and might think that the child is doing it intentionally or just acting out, or the noises that they're making they're doing on purpose to distract the class or be funny or get attention. So talking to teachers about that, and talking to teachers and advocating for teachers to ignore the child in class if possible. This is a letter example that is from the Tourette Association of America that is basically just advocating to a school saying, like, I have a tic disorder. This is what it is. This is what's common with it. Please just ignore it. Those kinds of things. And same with, this is like a little medical card that some people like to carry like in their wallet or with them to give out to people they see in public or to schools, that provides a little bit of information on what Tourette syndrome is and kind of what they're doing. I think that advocacy and education piece is huge and can be really hard and daunting and overwhelming for sure. Social communication. So we see that individuals with Tourette and tics have lower self-identity, self-confidence, and self-esteem. And that can definitely be a factor from the tics, whether the tics are making it physically hard to talk with peers. I had one individual tell me, well, I can never go to the movie with my friends because I have so many vocal or phonic tics that I can't be in a quiet movie theater. That just won't work. Or I'm trying to talk to my friends and I can't even tell them a whole story because of my tics. So thinking about that, and that's also where CBIT kind of pairs in nicely to address the tic, but then also we can work with the individual on how they can advocate for their peers or coming up with alternative activities. Could they watch a movie at their house or plan something else with friends? The other really big one, so just kind of like supporting those advocating skills and navigating bullying situations. Unfortunately, that's way too common, I think, for all individuals, as well as specifically for individuals with Tourette and tic disorders. And then I think a big one is finding community support. There are some really nice youth ambassadors out there. If you go to the Colorado TAA.com website, you can reach out and get paired with some youth ambassadors in the area who are other peers and teens with tics or Tourette's, as well as this picture is from the Tourette Association of America, and they have some additional resources and tools for teens or parents and caregivers. But that social piece, I think, is a really important one to address and make sure that we don't overlook. Sleep. So again, this number can vary, but we see that like about 65% of individuals with Tourette syndrome have difficulty falling asleep, whether it's because of their tics, whether they're trying to fall asleep, or some of those other comorbid, co-occurring things like anxiety or stress related to sleep. This visual on the side is just talking about the ABCs of sleeping, and it's going through, and this is something that as an OT we think about a lot for younger kids as well as older, having an age-appropriate bedtime and wake times that are consistent to ensure enough sleep. Schedules and routines even during the day, and a schedule and routine to go to bed. Thinking about the location of sleep. It should be quiet. It shouldn't be bright. It should be dark. Electronic use, not being on phones or tablets or even computers before bed. Thinking about that exercise and diet and how we can use those to support sleep. The positivity, I think that's a big one, is the family conflict and the emotional environment, how families can support positive sleep environments. The independence of making sure individuals can sleep by themselves, and just making sure throughout our day our needs are met, whether it's emotional or attachment needs. But I think that's something that I think about for any individual who were having difficulties with sleep. Those are kind of a lot of key factors to it. So as an OT, I think about our sleep hygiene, our bedtime routine, and then for sure tic management at bedtime. I feel like a lot of individuals who I've worked with, and I haven't worked with a ton so far, but report that they have a lot of tics right before bed or while they're trying to fall asleep. And I think if we think back to the sensory component, it's usually a quiet time. Sometimes they're more anxious at bedtime. There's sometimes a lot on their mind, or their mind's just kind of racing all over. So that's something that can be addressed in CBIT or just kind of through just a regular OT outside of CBIT. But we also see the less sleep an individual gets, the more tics that they'll have during the day. So that's another one where like supporting sleep is super important. We also see if there's less sleep, individuals are more on edge. I think a lot of us can potentially speak to that. I know when I don't sleep well, I'm not the best person the next day or the next few days if my sleep's been impacted. So I think it's a really important thing that can easily get overlooked. relaxation techniques. So Kate kind of talked about some of these, and we absolutely can talk about these in the context of CBIT, but I work on these strategies with a lot of my individuals, especially thinking back to self-regulation, whether it's that progressive muscle relaxation, yoga, exercise during the day. We don't want to be exercising before bed, but we know that if we exercise during the day, it can improve sleep. Meditation, diaphragmatic breathing, and then grounding strategies. Those can be like thinking about things you see, hear, smell, touch. I love playing like I Spy games with the alphabet, or thinking of words that start with each letter of the alphabet as kind of like a calm down, wind down game, and can be good things to incorporate kind of before bedtime, especially because we don't want to be on phones or on playing video games, watching TV, those kinds of things. So kind of in summary, if we look back, we kind of have talked about all of those things on the top of the iceberg with Kate's help, and then all of the things below, which was hopefully what kind of got highlighted here. And as I mentioned before, it's not all inclusive. There are lots and lots of different things, and every individual is different. Even if we say 60% of people with Tourette's have X, Y, or Z, it doesn't mean that you do, or you might have something that is less common, and it doesn't mean that it's a bad thing. It just means that as an occupational therapist, we can kind of use our lens to look at all those client factors and think about what do you want to do or need to be doing, and how can we help with that. So just kind of in summary, this is another quote I like from a very well-known OT, and it says that occupational therapy practitioners help people live life to the fullest no matter what. They provide practical solutions for success in everyday living and help people alter how they arrange their daily activities to maximize function, vitality, and productivity. So just kind of in summary, and I'll go through this pretty quick because Kate did a great job highlighting it too. We offer OT services here outside of CBIT. To get OT services, you just have to contact your primary care provider or neurologist to get an OT referral. And then you can always ask your PCP for who are the OTs in your area that you could see. We have OTs here, as we mentioned, as well as you can find CBIT providers on the TAA website. And I can't speak for all the CBIT providers, but I know here, Kate and I provide CBIT, but we provide lots of more traditional sensory regulation based OT as well. So you might be able to reach out to a CBIT provider and see if they could offer some of those services, as well as I think some of these topics can be brought up with a CBIT provider.